since we have your eyeballs, I want to let you know about something really special we have going on next week. This is the OpenNotes drop-in clinic. It's happening all next week. So every day, for 2 hours each day, we are live via Zoom and available and answering questions related to OpenNotes in the context of the 21st Century Cures Act. This is happening Monday, March 29th through Friday, April 2nd. We have special guest experts each day, so pop in and out at any time during these 2 hour slots. You can stay for 10 minutes or 2 hours and share it with your colleagues. Just go to the homepage at opennotes.org and sign up. You can look for the section that says the Join the Zoom link. We hope you'll join us. So I'm going to officially start the webinar now. Welcome to today's case study webinar on open inpatient notes featuring real-world experience at UC San Diego Health, as told by their Chief Medical Information Officer, Dr. Brian Clay. My name is Liz Salmi, and I'm the Senior Strategist of Dissemination for OpenNotes, and I'll be introducing you to the cast of characters along the way. For everyone who just joined us, welcome to today's case study webinar about open inpatient notes at UC San Diego. We're excited for this session and glad you're with us. We're presenting in 2 segments. First, you'll hear from Dr. Cait DesRoches, Director of OpenNotes, and then second, you'll hear from our special guest presenter, Dr. Brian Clay. Then we'll transition to open Q&A and dig into what you've been asking in the question box. So first, I want to introduce you to Dr. Cait DesRoches. Dr. DesRoches is the Executive Director of OpenNotes and an Associate Professor of Medicine at Harvard Medical School. She is a distinguished health researcher with expertise in emerging trends in healthcare delivery. Dr. DesRoches, I hand it over to you. And you are on mute.
I am off mute.
Classic.
Thank you, Liz. Very excited about this webinar today. Super excited to have Dr. Clay on with us to talk about their experience with sharing inpatient notes. I'm going to give you a very brief background. So this is only going to be a couple of minutes, and then we'll get right into the main event. But I did want to start off just by giving you an idea of, since many of you have never come to an OpenNotes presentation before, just giving you an idea of sort of who we are and what OpenNotes is. And I'll start by talking about what OpenNotes is not. So OpenNotes is not a software. We are not app developers or coders. We don't have a server full of notes somewhere that we're mining for information. We are a philanthropically funded initiative that's made up of researchers and communication experts, and our focus is on improving healthcare through greater information transparency. We receive all of our funding through either grants from philanthropy, so places like the Cambia Health Foundation, the Commonwealth Fund, the Gordon and Betty Moore Foundation, and some federal grants, and then a small amount through private philanthropists, but we are not commercially supported in any way, and we're not selling any products. Next slide. So what is OpenNotes? OpenNotes is simply when patients can easily read their visit notes. So we are electronic health record vendor agnostic. Our goal is for patients to be able to log onto the portal or log into their smartphone and easily access their notes. So that is what we're talking about here. And I'll be really clear to just say what we've studied and what we've worked to disseminate best practices about is outpatient notes, ambulatory care. So we have a lot of data and a lot of information about how to do this in ambulatory care settings and behavioral health settings. We don't have a lot of information about inpatient notes. There have been places that have been doing it. The VA has been sharing inpatient notes for years. Other places like Mayo, the Mayo Clinic have been sharing their inpatient notes. And today we'll hear more from Dr. Clay about their experience. Next slide. So currently what we know about the extent of note sharing in the US is that there are 260-ish organizations that are sharing notes with patients through their patient portals. Those patient portals have a total of 54 million people signed up. Now, This is likely an undercount. I'm sure there are organizations that we don't know about, and we know that many organizations have opened their notes over the last few months as they've started to get ready for the rule. When OpenNotes began as a pilot project in 3 organizations, the 3 places where you could find your notes were at Beth Israel Deaconess Medical Center in Boston, Harborview Hospital, which is a safety net organization in Seattle, and Geisinger Health System, mostly serving a rural population in Pennsylvania. That pilot was in 2010. The results were published in 2012, and based on the benefits seen reported by patients and the clinician experience, which was primarily, this was fine. It helped some of my patients and it really wasn't a big deal. OpenNotes has spread over the last 10 years across the country with implementers in every state. And you can see, I'll just explain briefly, the darker purple on the map means we have more implementers. So the West Coast and sort of in the middle of the country, the kind of Illinois, Michigan area, we have quite a few implementers. Next slide. So prior to this time period, OpenNotes was a voluntary process. Organizations could choose to share or not share the notes through the portal. Most electronic health records gave them the option, but really it was up to the individual organization. That will change on April 5th of this year. On that day, the U.S. Department of Health and Human Services says that we are implementing the 21st Century Cures Act. So the 21st Century Cures Act in passed in 2016 had a line in it that essentially directed HHS to improve data interoperability, so how it flows between organizations, and required healthcare organizations to provide patients with all of the information in their electronic health record without additional cost or delay. Fast forward 5 years, almost 5 years later, and a lot of discussion about what all means, and we get to the USCDI, so the United States Core Data for Interoperability. That data set specifies what needs to be exchanged and made available to patients on April 5th. And you can see in this little box, it includes 8 kinds of notes, both inpatient and outpatient notes, consultations, discharge summaries, progress notes. You can see there's 8 different kinds of notes there. Now, there are some exceptions. HHS recognized that there are times when it may not be a good idea to share a note with a patient. And the primary one is the preventing harm exception. So if a clinician has a good reason to believe that sharing the note with the patient would cause physical harm to that patient or another person, they can hide that individual note. Now, in using this exception, providers have to have a good reason, and the blocking of the note can be no broader than necessary. So they can't just set all notes to be blocked under this exception. It has to be note specific, and there has to be a good reason for it. Other exceptions include a privacy exception. So if a patient says, please don't share this note to the portal because someone else has access to my account, or I'm worried someone else will see it, providers don't have to share in that case. And then there are other more technical exceptions related to we can't share electronically because we don't have that capacity, and a few other things. So there are a few exceptions, but they are very specifically written, and they are not, you really can't interpret them as kind of broad permission to block notes. Next slide. So that is it for me. I am going to turn it over to Brian Clay. Actually, I'll turn it back to Liz to introduce Brian. But I'm here through the webinar, so if you have questions, either throw them in the chat. Deb knows more than me, so she can answer some of your questions, or we can talk about it in the Q&A period.
Thank you so much, Cait. Yes. So I appreciate you setting the stage for our next presenter, the main event. Dr. Brian Clay is a member of the Division of Hospital Medicine and Chief Medical Information Officer for UC San Diego Health in San Diego, California, which would be a great place to be hanging out right now. As CMIO and a hospitalist, Dr. Clay is dedicated to optimizing workflow in the electronic health record and improving EHR knowledge and experience for his clinician colleagues. He helped lead the UC San Diego Health rollout of ambulatory OpenNotes in May 2018 and inpatient OpenNotes this last fall in 2020. We're really excited to learn from him today. There's so much we don't know that we're excited to learn about. Dr. Clay, I hand it over to you.
Thank you, Liz, and thank you for offering me some time this morning to talk about this topic. I don't have all the answers either. As Cait pointed out, the ONC is causing all of us to learn together, but I have ideas. And I want to present about 20-25 minutes of material and leave plenty of time for open Q&A, because there's a lot of opportunity to discuss some of the nuances in the hospital setting that may not be direct parallels to ambulatory medicine and all of the work that OpenNotes has done to date. Next slide, please. So in addition to all the things that Cait said OpenNotes doesn't do, they also didn't pay me to give this talk. And I have no other relevant conflicts of interest to disclose. Next slide. A little bit about UC San Diego Health and our demographics. We're the premier academic medical center in San Diego County. We have 2 hospital campuses, one of which in the La Jolla area serves as more of a community hospital type population, and one closer to downtown San Diego, which is more of a county hospital, underserved type population. So we get a good broad patient demographics. We are a teaching institution. We have residents, fellows, medical students, and so on. We also share our electronic medical record instance with UC Irvine Health, which is a separate UC health system, the faculty medical practice at UC Riverside, and several non-academic outpatient clinics in the greater San Diego area. So decisions we make about OpenNotes and configurations and things like that go beyond UCSD, and so there's a lot of joint discussions about how to proceed on some of these questions. Next slide, please. So I often get questions about OpenNotes, and I often refer physicians and other people to the opennotes.org website. Cait already showed some of the content that is there. I'm going to touch a little bit on the known literature, but I really want to commend the OpenNotes organization for aggregating and summarizing the known literature on OpenNotes in their research page. It's really quite nice. And it's just a great repository of information to clarify what OpenNotes is all about. Next slide. So to that literature, we've now had a lot of experience. In fact, in the last 12 months, a 7-year retrospective was published, I think out of Beth Israel Deaconess, on their experience for OpenNotes over that time, and following up on some of the more long-term effects of making that change years ago. But I'll just reinforce what Cait said at the introduction, that the studies tend to have very common themes, and they're largely survey-based. Asking patients, asking clinicians, physicians, what they think about sharing notes with patients and doing so easily. And the themes are basically that when you ask patients, once they have access, they find it useful. They find that they understand their care plan better. They feel they have perhaps an improved relationship with their physician. And it's just, it's all neutral or upside. When you survey physicians about this, the very common theme is that the physicians think it will be more work for them to write the note. They'll have to really think about terminology, abbreviations. They're worried about medical jargon. They're worried they're going to get a lot of questions from patients about sharing notes. And then when you survey them afterwards, they'll say, well, I didn't really change how I wrote my notes all that much, maybe a little bit of the margin. And no, I didn't get a lot of questions from patients, maybe a few. And OpenNotes Go Live tends to be a non-event. Which is actually what you want. You want to provide this upside benefit to patients at little to no intrusion to the clinicians. Now, there are a few studies out there showing actual hard outcomes. Medication adherence has been studied in a couple of studies, showing that patients stick to their medication plan better if they have the notes, because they can see why those medications are being prescribed. What there isn't is a lot of research in the hospital setting. We have one study from 2015 that, again, surveyed clinicians and patients in an emergency department setting. And while that is in a hospital, the themes were very similar, but it's largely an ambulatory setting in this case because they weren't surveying patients that were hospitalized per se, just those who were seen in the emergency department. And so it's more of a high acuity outpatient setting. And so it's not surprising that the findings were similar. Next slide, please. So what's different about the hospital? A little background on me. I'm a hospital medicine physician by clinical practice. I've been on faculty at UCSD for 17 years and even predated the EMR implementation at our hospital. And so I've kind of seen the gamut as the technology has evolved. And in our hospital setting, when we think about sharing notes with patients, some things that are different. Well, there's a lot more team-based care. We have residents and students in the outpatient setting. That is true. It's much more prevalent in the hospital. In addition, other clinicians and other interdisciplinary services will see the patient. Case management, social work, dietary, physical therapy, and so on. You know, there's lots and lots of user types in the hospital, and many, many notes get written. If you think about an outpatient visit, there's basically one note from the doctor, maybe two, but a hospitalization that spans days or weeks could have dozens or hundreds of notes. How do you present that to the patient? How do you think about timing? Something we'll talk about. And what does that, look like and mean for people who are writing all of those notes? These notes are close together in time. There's at least one note every day or even several notes per day if acute events happen. And the daily progress note on a hospitalized patient tends to have a lot of repetitive material. Patients aren't that different day to day. Things are evolving perhaps slowly. The patient hopefully is improving, but you're reiterating a lot of information that you've already said previously, and that may give a different flavor to a patient who's reading these notes as opposed to outpatient notes where you're being seen every couple of weeks, every couple of months, once a year, and so on. The emergency department we talked about, those notes may be a little bit more streamlined. It's a fast pace of care and fast patient throughput. And my emergency department colleagues tend to write down just the highlights and put a lot more into, here's what I'm thinking might be the very critical diagnoses that I don't want to miss, as well as what diagnoses I think are most likely. And so those notes, again, a little bit different than the outpatient notes that the OpenNotes project has focused on. And then the hospital setting is not just a patient sitting up on a medical unit, but patients go to the operating room. Anesthesiologists write notes. There's the dictated operative report. There's all kinds of unusual situations or different situations in a hospital setting that just don't occur out in the clinic. Next slide, please. So Cait mentioned the ONC and the 21st Century Cures Act, and I want to give a little bit of background on this because I think that, for better or worse, the 21st Century Cures Act is catalyzing an implementation of inpatient open notes that probably would not have happened quite so quickly in its absence. Next slide. So what is the 21st Century Cures Act? Well, first and foremost, it made information blocking illegal. This is a law that was passed by Congress in 2016 with broad bipartisan support. It dealt with many things in healthcare, not just transparency of information, but there was a focus on interoperability. And the ONC, the Office of the National Coordinator, which is within Health and Human Services in the federal government, and the group that brought us the meaningful use regulations back in 2009, put out a report that said that lack of interoperability and transparency was hindering electronic health records from improving patient care. And so part of the 21st Century Cures Act was a provision that purported to penalize information blockers. And what that meant, at least at that high level in the law, is interference with access or exchange of electronic health information, whether that be between healthcare systems or systems to patients, or to third parties who the patient might want to have their health information. But the law was broad, and there weren't really specifics about what information blocking was or any of the exceptions that Cait already mentioned. Next slide, please. So for years, all we had to do was attest annually to CMS that we promised we're not information blocking, and that was sufficient. However, the ONC came out in May of last year and published a 1,200-page final rule that we all devoured instantly in the informatics community that unpacked what information blocking actually meant, gave examples, outlined the list of exceptions that Cait mentioned, and the two that are really relevant to those who are writing a note in the moment are the patient harm exception and the privacy exception, which have already been mentioned. It defined the data set that patients have a right to see. Cait showed the USCDI, the United States Core Data for Interoperability, on one of her slides. And one of the new things is that clinical notes was included. And so that's the focus here that we're going to talk about. And then it set 6 months before they would enforce penalties. Now, when that rule was published, COVID was just getting underway. And so there were a number of implementation deadline delays due to the COVID-19 pandemic, and the current deadline has been moved to April 5th, 2021, which is just a few weeks from now. As this rule was published, it generated a lot of questions, and a lot of us sent specific use cases to the ONC asking for, what do you mean? What do you mean by this? What does this mean? And the ONC has published a couple of FAQ documents since then, and the most recent one in January made very clear, and I'll show you on the next slide the actual excerpt from the website, that clinical notes is broadly defined. And it's not just notes written by physicians, it's really all clinical users and all clinical settings. So this put on the table a very different approach that needed to be taken, and not just, well, whatever we did for outpatient OpenNotes, we'll just transplant that in the hospital and it'll be easy. I will make one last statement about the ONC and this rule, and that is the USCDI is what patients have a right to get easily until late 2022. Then they have a right to everything in their electronic medical record. So the rule is actually quite impactful, and this last point is more of an issue for our EHR vendors and their coding, and less for us, because they need to code things into the patient portal that really makes transparent all of the information, not just notes, in the health record itself. Next slide. So this is the USCDI, and this is taken from the ONC website at healthit.gov. And many of the things in here are already in our patient portals, things like a problem list, immunization history, who are the care team members, allergies. All that is already in place. None of that's an issue. But the two areas that needed addressing by the informatics community are clinical notes, which we're talking about here, and laboratory tests. Because many of us had put time delays on our lab tests, and we won't go into that now, that's a different topic, but the focus has really been on notes and tests and making those quickly available in the patient portal and broadly available so that we make sure we're not missing any content. Next slide, please. So when the rule first came out, we all went to the ONC website, and the ONC had this page in USCDI version 1. And we looked at this and we said, well, these are really physician type notes, consult, discharge summary, history and physical, procedure, progress note. We all made note of imaging, lab, and path. We said those are actually results, and the ONC is a little bit confused. We're going to do that anyway, but it's a separate topic. Next slide. And a draft version of USCDI version 2 is out, and they've clearly recognized that. They've moved those three things over into the results bucket. But they've left the website like this. And so people were still thinking, okay, it's just doctor notes. What about residents? What about fellows? What about medical students? We'll think through that. Next slide. But the ONC put out an FAQ, and people asked them point blank, what about nursing? What about pharmacy? What about everybody else? Are those included? And the ONC said, yes. It does not specifically include or exclude notes or other clinical observations based on the type or specialty of the professional who authors them. And so the informatics community has taken this update from January to mean this includes nursing, therapy services, care coordination, and so on. It's everybody who writes notes on a patient in a hospital setting. So it's a broad implementation that we're all looking at for April. Next slide. Here's the overall timeline, and then we'll move off of the ONC content. And you see here, April 5th is the information blocking provision goes live, and we need to have all this information available in the portal for patients. And then the October 2022 deadline, where patients get a right to everything, not just what's in the USCDI. Next slide. So what did we do at UCSD? Well, as Liz mentioned, we did an implementation in 2018. After we had the OpenNotes crew out to give a presentation that spring, we decided to go live all across ambulatory, and we set up sharing of notes by default in our primary care clinics. And it was a non-event. there were a couple patients who called and had questions. Well, we basically turned it on and patients saw notes and it wasn't really a big deal. In all the specialty areas, we allowed them to opt in, and we knew that there wouldn't be a whole lot of opting in, and some areas did. Most did not do a lot of this, as our data showed. And so, again, the 21st Century Cures Act is kind of catalyzing a change here, in addition to making sure all these notes are available in the patient portal. It is also a conclusion from the ONC regulation that we have to be sharing these notes by default, but allow providers to opt out for one of the ONC allowed exceptions like harm or privacy. We started thinking about inpatient open notes. There's actually a phase 0 I didn't put on the slide, and that is we decided to start sharing discharge summaries by default back in May of 2020. This is something that we would frequently, as inpatient providers, get a request from patients for a copy of the discharge summary, especially if their care was elsewhere. They wanted to have a copy in hand to make sure their doctor could see it. And so we decided to just turn it on. And again, it was a complete non-event. We started sharing all our discharge summaries. We saw very few instances of people opting out of the sharing while they were writing the note. And it wasn't really a big deal. And I've asked my hospitalist colleagues, I've asked our medical records department, were you getting questions? Were you getting complaints? And really crickets. So having discharge summaries available was not a big deal. Looking forward to November of last year, which was the original implementation date for the ONC before the COVID-related delays, we said, well, let's turn this on for our faculty, for our attending physicians, all clinical areas, outpatient and inpatient includes perioperative and the emergency department, and let all the clinical note types, let's set them all to share by default. Let's watch what happens. And then phase 2, we were originally going to do in February, and then we moved it to April, and we're going to do this in 2 weeks, is everybody else, our residents, our fellows, all of our care coordinators, nutrition, dietary, I've named many of the services, nursing, and so on. Now, as to timing, at this time, we are not releasing those notes in real time. We are sharing notes upon patient discharge from the hospital setting. So if they came to the ED and they're going home, then once they're released electronically, they'll see their note if it's done. And then if they're hospitalized, once they're discharged electronically, they'll see their notes once they're done. That's where we're starting. It's kind of unclear in the ONC rule what the timing question actually has as a correct answer, but we'll talk about that in a little bit. Next slide, please. So one of the nice things, we use Epic as our electronic health record at UCSD, and one of the nice things is that it has some intrinsic dashboard and tracking data that we can pull fairly easily. And so I pulled this just in the last couple of days. So this is data through the calendar month of February. And so you can see the monthly data even up to and including our November go live for our attending physicians. And I've split this out by the emergency department, our perioperative and procedural areas, and our inpatient units, which include the ICUs. And the differences here, what you're seeing is basically the percent of patient notes that are shared, and then of the notes that are shared, the percentage that are viewed by patients. And I will say our ambulatory data for, again, it's attendings only, and it varies by clinic, but it's roughly 40% shared, and of those, roughly 20% viewed, which are very typical numbers in terms of that, how often do patients look at notes. So in the ED, we're not sharing as many, but I think that is because more notes are written by house staff and not the attendings. But the view rate is actually higher, which is very interesting. In the perioperative areas, we're sharing more than we are in outpatient. Now, there may be a couple of reasons for this, one of which I am quite certain is that many surgical notes, operative notes, are still dictated and are not entered directly in the electronic medical record. They're edited and signed in the electronic medical record, but it may not be obvious to those authors how they could unshare those notes. And so more of them are getting shared, and a fair amount of them are getting viewed. And then in the general inpatient space, we have a much larger prevalence of residents, fellows, physician assistants, and nurse practitioners who are authoring notes. And so it's not surprising to me we have fewer notes that are shared. In a couple of weeks, I expect all of these numbers to go way up. And the percent of patient notes that are viewed is lower. probably because patients are still a little unclear as to how to access this in the portal, and it's a relatively new phenomenon over the last couple of months. Now, next slide, please. This is tons of notes, and these are thousands and thousands and thousands of notes being shared every month. What is the patient response? Well, Epic can also give us some tracking data on patient portal messages, and the patient portal in Epic is called MyChart, for those who don't know. And patients can originate a MyChart message called a patient medical advice request message, and that is the message type that's used for just a question that comes in from a patient. And we wanted to look very closely as we turned this on for attendings in November, whether we saw a bump in traffic. And I know the graph is small, but if you look at November 2020, there isn't really a bump. We do see a bump in January, but I am entirely convinced that that is related to the advent of the availability of the COVID vaccine. And we were scheduling all of our patients through MyChart, and there were a lot of questions about that process. But we did not see a bump in traffic here. We also, and I've asked our medical records department, they did not get an increase in phone calls on this topic. And those phone calls are uncommon anyway. So again, kind of a non-event, which is what you aim for. Turning this on for attendings didn't seem to be a big deal. Next slide, please. Now, as we approach 2 weeks from now, and we broaden this out beyond the attending physicians, I've lost count of the number of brief presentations to various stakeholder groups, whether that's organizational leadership and governance and things like that, but also directly to nursing, pharmacy, the therapy services. I met with our patient and family advisory group twice to let them know, you as patients who are on MyChart, you're going to start seeing this. Here's what it looks like. Here's what it means. Here's where you go if you have questions, and so on. And there's other groups on here that have reached out to me that I haven't listed. Spiritual care, our chaplain service is a big one. And most of these folks are kind of tentatively supportive of the idea. And I think this is very consistent with what we see in the ambulatory OpenNotes literature. Like, people generally are in favor of the idea, but immediately think of the case where it could go sideways. And that's very natural and very normal. And part of my job as the Chief Medical Information Officer is to, one, validate those concerns, but also to reassure that those are unusual situations and that we have ways to mitigate that. Next slide, please. So a lot of this is about educating those who would write notes on what OpenNotes means. And so I hit a couple of points when I give these talks to stakeholder groups. First and foremost, people always ask about medical jargon, abbreviations, and confusing language. It's clear in the outpatient literature. Patients know these are medical documents and that medical language will be used. Patients have the ability to, many patients, not everyone, patients have the ability to look up terminology, to go to WebMD or what have you, or they have people in their family who are in the know in medical jargon. They can get context. And this is not really a barrier from a patient standpoint. And they know that the note is written for multiple stakeholders. It's a legal document. It's also communication to other physicians about the care that was rendered and so on. That tends not to be a big deal. We've talked a number of times about, well, is this going to cause a lot of phone calls and MyChart traffic? And not only have we not seen an increase in MyChart or medical records, I talked to our patient experience office. We have a We Listen phone line where patients can call in with complaints, and there's no broad increase. I'm aware of one phone call where a patient saw their surgical operative report in MyChart and called up to say he didn't want to be able to see that. And so I talked to the patient experience office, gave them the 21st Century Cures background, said, well, we're going to make this proactively available. The patient is under no obligation to look at it. And without getting too deep into the weeds of how MyChart works, it's actually about 4 clicks deep to find a note. You're not going to accidentally happen across it. You have to go looking for it. And so I think that works in your favor because, again, you can reassure people that this is not going to pop up in the patient's face and say, you need to read this note immediately. Finally, I always remind everybody that this is not really new. The patients have had a long-standing right to their medical record that predates the 21st Century Cures Act. It predates the HIPAA privacy rule, which is now 20 years old. They've had this right for a long time. And our medical records department gets about 500 requests through MyChart every month for a copy of their record, and what they get is a PDF of all their notes and other content in about 48 hours. And that data has not changed since November 2020. So people are not asking to pull more data or less. And the fact that about 20% of notes are being viewed is consistent with that. Some people just want to get a PDF when on demand rather than look at material when it comes in. Next slide, please. So timing. In the outpatient setting, it's kind of easy. You know, you go see the doctor and then you leave, and the doctor finishes up the visit documentation, which usually is within 24 hours in most cases, and then the note is visible in the patient portal. Well, in the hospital, patients might stay for days or weeks, and so what do you do with that? As I said, currently we're releasing shared notes to patients upon discharge from the facility. Our eventual goal is to move this to a following morning release of notes from the previous day when patients are in the inpatient setting. This will be kind of a phase 3 that we tackle next. But we really want to do some additional education, especially with our residents and medical students about this. In terms of the emergency department, if somebody goes home, as I've already mentioned, this is essentially a high acuity outpatient visit, and so it's very similar. When the ED note is wrapped up, then the patient will be able to see the note in my chart. People have raised some concerns about real-time access to information in the ED, specifically to the ED, and one of our sister UC Health campuses cited this was more about lab tests than notes, but that patients would come in, and if they got the information literally in real time, they saw the lab test the moment the results were available, then they felt they got what they needed. Maybe they were normal tests, they felt reassured, and they left without seeing the doctor. And so we're kind of taking that into consideration, and we probably will continue to only release notes from the emergency department after the patient leaves, again, because we're considering it very analogous to an outpatient visit. In terms of test results, we're still thinking through that, but that's a bit of a different topic. Now, there are some inpatient areas where there may be heightened scrutiny, extra legal protections depending on your state, or regulatory requirements about sharing records with patients. The ONC rule has a specific exception, not only for harm or privacy in the general sense, but also for psychotherapy notes. And so this has been a big discussion with our mental health providers. And psychotherapy has a very specific legal definition, and it is not all psychiatric care. Psychotherapy is a small proportion of that, and psychotherapy is almost never done in the inpatient setting. That's almost always an outpatient phenomenon. That being said, California does have a state law in the books about not sharing medical records with patients who are on a legal psychiatric hold. And so we are thinking our way through that, and how do we balance these things between the 21st Century Cures Act, which in the ONC frequently asked question says general mental health management is in scope. Those notes need to be shared with patients, versus other things that are on our statutory books in the state of California that we need to consider. So some of those are still being worked out. Next slide, please. I want to bring this home to anybody who's on the call who is undergoing the same journey that we are at UCSD. This is a big exercise in change management. And the easy way to do this would be to go to everybody and say, this is a new federal law, we have to do it, we're turning it on April 5th, thought you should know. And if you don't like it, write your congressman or write your senator. However, that tends to be relatively unsatisfying through the lens of the end user. And so we have decided to do this in, as I've described, kind of a phased approach. Maybe we're not giving notes right away in the inpatient setting. Now we are advantaged because there's years of literature on the outpatient experience with OpenNotes. And so we are reassured that this should be, in the great scheme of things, a relative non-event. I've mentioned some of the concern about real-time access to info in the ED. I think that's a specific use case that may need a slightly adjusted approach. And I mentioned psychiatry with regulatory requirements there. What I've been doing and what everyone should do is discuss concerns with stakeholders, meet with anybody who wants to talk about it. Say, I want to talk about OpenNotes, just say, name the time and place, I'll be there, I'll answer any questions you have. And even before we brought our attendings on board, I met with our cancer doctors and our HIV medicine clinic, which has a potentially challenging group of patients and a lot of sensitive material. And then communicate. You know, blast emails are great, but they're necessary, but by no means sufficient. We've spun up an intranet page with a number of frequently asked question documents with links out to the ONC page and other internal references so that we have something to point people to if they want more in-depth discussion or unpacking of what about psychiatry, what about adolescent medicine, and so on. Next page, or next slide. So what do I recommend our note authors do? Well, again, taking a page from the outpatient experience, you don't really need to overhaul how you write your notes, but it's a good opportunity to remind people that patients look at them. So some easy things to do, and there aren't many of these, you know, avoid troublesome acronyms. And the one that always comes up is SOB for shortness of breath. Well, don't put SOB in your note because a patient might skim it and take it the wrong way. You want to watch your language for what I call value-laden terms, you know, poor historian, patient declined to do this, medication non-compliant, those things. And there are better terminology options out there, and that is a little bit of a habit change, but I think a good one that's generally recommended, and not just because patients are going to see notes. Now, we all use commercial, I'm assuming many of us on the call are using common commercial electronic medical record systems, and most of those systems have the ability for individual users to create their own note templates. It is a really good idea to remind your users to review their personal templates, and as well as any system level templates that you have built in the system. Look for some of these issues. Also look, especially with daily inpatient progress notes in mind, look at them for pre-populated information. This is not a talk about copy and paste and about carrying forward inaccurate information, but that is a well-known phenomenon in the hospital setting. And if there is going to be less of a barrier for patients to see these notes, we need to be paying attention to making sure that every note every day is accurate. And one thing that I'm hoping is that, and this is a very common phenomenon in a teaching institution, that every day's note builds on the previous one. They don't ever lose anything, they just add. And a note just gets bigger and bigger like rings of a tree and then becomes a discharge summary on the day the patient goes home. However, there are professional fee billing rules that are streamlined that went into effect in January this year for outpatient and may go into effect in January of next year that take away from the need to write down so many body systems and so many physical exam findings and so on. We may be able to move to more of an interval progress or update note every day and still have the substrate for billing and have more streamlined content for ourselves and for our patients. And so that's on the horizon, and I'm very much looking forward to that because I think it's going to work in our favor. Finally, and this is not an individual responsibility, but an organizational responsibility, you need to look at where all your clinical notes come from. Not everything is entered directly in your electronic medical record. Some are entered in third-party systems, whether it's for GI endoscopy procedures or radiation oncology. You know, you may have specialty systems that send notes over to your core EMR via an interface. And if you don't have the opportunity to have an author withhold a note for the harm or privacy exception, then you need to be aware of that. And you need to educate those users. And there's usually a way you can work it out, but it's going to take some education. If you want to withhold that note for an allowed exception, here's how you do it. It may not be obvious. Next slide, please. So just to wrap up, and then we've got about 15 minutes for Q&A, we've been slow to bring OpenNotes to the hospital setting, and the 21st Century Cures Act is catalyzing this, and everyone at the same time. So a lot of people are asking the same questions, and everybody is kind of coming up with the answers themselves. But I think that the lessons we've learned from outpatient OpenNotes generally apply to the inpatient setting. There are some nuances that are different in the hospital, but most of the things do translate. And what you can do that will benefit you the most is educate your note authors on what they can do, what they can't do, what the law is, and what the benefits are. And then communicate. Here are go live dates, here are updates, here's why this decision was made, and give them a way to ask questions and to continue the conversation. The conversation isn't going to end on April 5th. It's going to be ongoing for a while. especially as we look forward to October of 2022, and all of us are going to have patients that have access to all of their information. Patient data transparency is going to be a new normal and is going to be something that we deal with on a daily basis. So I'll stop there. I think the next slide is just a thank you slide. And ask if there are any questions in the chat or anything that we want to talk about. We've got some time.
Thank you so much, Dr. Clay. I feel like I've been waiting for months for your presentation, so it's very satisfying. As we transition to Q&A, please enter your questions in the chat box. And while you're inputting your questions, I just want to remind you of a few things. April 15th, we have another webinar coming up about OpenNotes in the safety net setting. And then a reminder, all next week, March 29th or April 2nd, we're live OpenNotes with a drop-in clinic 2 hours each day. All right, transitioning officially to Q&A. Moderating Q&A is Deb Wachenheim from OpenNotes. You will hear her voice as she starts to ask, the hundreds of questions that have been coming in over the last 45 minutes. Go, Deb.
I will try my best. So one person sent in a few very good questions. I'll say the 3 in a row, and then hopefully you can just give answers to each of those. Some concerns. Number 1, often as hospitalists, we include differential diagnoses such as malignancy. So asking about that. The second one, radiology reports often have incidental findings that to lay people might sound worrisome, or they may say something like cannot rule out malignancy, etc. And then have you addressed nursing to be aware, because notes such as MD paged no response documentation may have medical legal implications.
So those are great questions. Let's tackle the first one, the differential diagnosis. And as I told Cait before the webinar started, I'm probably going to give this answer a couple of times. That's not a new phenomenon. Patient has a right to the medical record. Patients have gotten copies. They've already seen this. This is just going to be more of the same. That being said, I think that it is important to be mindful when you put down a differential diagnosis to label it as such. And I think if you do that, then you'll be well served. As opposed to, shortness of breath, considering da-da-da-da-da. But if you say differential diagnosis includes, the differential diagnosis is a medical term that people can look up and get context about. Whereas if I just say I'm considering, people might take that as I'm giving equal weight to all of the following things beyond this colon. Whereas a differential diagnosis implies that there's different weights to that. What I might say is the best practice is to follow up any differential diagnosis with most likely the patient has X or Y, and at least tell the patient, and that's a good practice anyway. I am thinking mostly about this because that's probably what I'm going to work up or empirically treat. Let me take the third question about the nursing notes. Nursing notes in general engendered a lot of discussion because a lot of them are, I want to phrase this the right way, required for regulatory reasons, but are fairly boilerplate. I'm thinking here of plan of care notes. And we've actually made the decision to exclude those from sharing because we think they don't have a sufficient enough clinical bent. However, the ordinary note that a nurse can write about whatever, which might include MD paged awaiting response, we feel compelled by the 21st Century Cures Act and the ONC rule to bring those in scope. Because sometimes it's patient found on ground, fell out of bed, unclear if hit head, doctor paged, will assess. Sometimes it's a clinical event. Sometimes it's something the patient reports. The patient's having a rash after an intravenous antibiotic is started. And so one of the things that we're all having to deal with is that we have not been preparing for something like this in terms of note granularity. In terms of how notes are defined. One of the things that I think will happen, and I'm not endorsing what I'm going to say next, is that I think I can educate to the harm exception and the privacy exception until I'm blue in the face. And we will be putting actually a prompt in the electronic medical record, not in April, but probably a month later when we do our code update, that if you elect to not share a given note while you're writing it, you'll get a drop down, well, tell us why. It's privacy, it's harm, the patient doesn't want to see it, short list. If somebody doesn't want to share a note, they'll find a way. And so one of the things I think this conversation doesn't end on April 5th is that what we'll be doing through the summer and through next year is analytics. We'll be looking at what are the practice patterns of our note authors, who is sharing, who is withholding, why are they doing that? We'll be surveying people, we'll be sending out questionnaires, and there's a lot of unknowns. So that was a long-winded way of saying, yeah, there are going to be nursing notes that could be viewed as problematic by doctors, but I'm going to turn that around and say it's entirely likely there may be doctor notes that are viewed as problematic by nurses. I don't want to be very doctor-centric from my own point of view. And the ONC says the patient has a right to this stuff. It's clinical material. I'm trying to remember what the second question was because I went a long time.
Radiology.
Radiology, yes. So this actually predates the inpatient OpenNotes discussion because many organizations have been releasing imaging narrative results for a number of years. And the discussion there has always been about timing because of the opportunity for the ordering provider, the oncologist who ordered the CAT scan, to be able to look at it, give the patient the context beforehand. However, under the ONC rule, most people are interpreting that as we need to give those imaging narrative results, if not immediately upon availability, then really pretty soon. And UCSD right now has a 4-day time delay on those results, but we feel we probably need to move within 24 hours to be fully compliant with the ONC at some point. One of our sister campuses is moving to immediate release imaging narrative results very soon. And there are several organizations in Northern California who've already been doing this for years. And this requires a number of approaches to education. One is you got to educate your ordering docs. Your patients may see this before you do and have a process for that. One is educating the patients. You may see this before your doctor does. Please give them some time to review and respond, as they always do. If you're going to have a clinic visit with them, discuss it at that point. Otherwise, please give them 2 working days to review all their results in their in-basket and get in touch with you to have a discussion. And a corollary education to patients is, if you don't want to know, don't look. And that sounds a little trite, but there's actually, I think, a lot of value in that. And part of this that my ambulatory CMIO colleague, Dr. Marlene Millen at UCSD is expert at is managing patient expectations. I'm going to order this scan. One of the things that might be happening is a cancer diagnosis, but we don't know. If you don't want to know before I know, don't look at the result. When it's in my chart, I will call you and we'll discuss the findings. So there's a lot of that, and this is new. This is workflow change. And you know, we no longer can be the, well, let's time delay these results 2 weeks so that the doc has plenty of time to review and completely frame the conversation. That ship has sailed. Now, as to the content, I think getting radiologists out of what I would consider a standard practice that is long-standing of listing more likely and less likely things on an imaging narrative report, and some of those things might be clinically disturbing, is not going to change anytime soon. I expect to clinically correlate radiology results until the end of my career. And I don't knock the radiologists for this. This is how they've been trained, and they are kind of one step removed from the patient transparency. They're not the ones getting called. I get that. And they have an obligation to kind of cover the needed things for context for the doc who ordered the test. So I think that how we deal with that falls into educating the providers, the ordering providers, and the patients. Radiology reports often include language like, often include considerations of things that are very unlikely, but remotely possible. We will have that discussion and we'll talk about the context and how likely things are. I think that's where it has to live. I think it's just going to be really, really challenging, at least in the near term. 10 years from now, who knows? But in the near term, how radiologists write their narratives is probably not going to change much.
The Cures Act requires release of all notes, not just those from April 5th forward. How are you making notes from prior hospitalizations available?
So prior notes, back to the end of time. So one technical answer and then one philosophical answer. So Well, because it matters, right? What can your system do? Can your system even do it, right? That's the first question. One of the 8 exceptions in the ONC rule is technical infeasibility. And so it may be, well, we can't. We can, as it turns out. Now, how Epic works, and this is true for anybody who uses Epic, there is a field somewhere in the database that is your OpenNotes go live date. And there's one. And we did an OpenNotes go live in the spring of 2018. So we have as our date June 6, 2018. So when we started turning on notes for our attendings in November 2020, it exposed everything back to June of 2018. And that's just how Epic works, because we weren't going to move that date forward, because then 2 years of outpatient notes would go invisible. Well, we don't want that. And so we had to message this to the docs. Now, so that's the technical thing, is that you may already have that data in your system. Be aware of that. Now, you can change that date. We could set that date as, January 1st, 0000 if we want, and show notes from the beginning of time. However, there are some, and the ONC says there's nothing in the rule that kind of says you shouldn't release older notes. They hedge a little bit. But the thrust of the ONC is that older stuff should be in scope. That being said, people are making what I think are very cogent arguments that, look, 5 years ago and 10 years ago when EMRs were very new, or at least we may have been on different systems. Many organizations have provided a link or even imported older notes that were written with no consideration of patient transparency in mind and predated the concept of the patient portal. We've only had things like MyChart for about 10 years, maybe a little more. And so really old stuff, why should that be in scope? That was from a different era and was written with none of this in consideration, and patients can access it a different way through the medical records department. It's not being hidden, but maybe it shouldn't be exposed quite so easily. And I will admit I'm a little sympathetic to that argument, especially notes that have been brought forward from an older system where there's no opportunity to go edit or suppress for a harm or a privacy exception. It just is. I think what happens at the end of the day, at some point, as we go live, as everybody goes live in April and a year goes by and it's largely a non-event and everyone kind of gets comfortable, I think what will happen is that people will elect to move that go live date back to inception in October of 2022. When the patients get the right to all of their content, they'll just say, you know what? We're just going to let this brew for a while, let everyone get used to it so it's not a big deal. And then we'll kind of go backwards in time in 15 months, or 18 months. It's not far away in the great scheme of things. We'll get there eventually. I just think that there's a very mixed response to whether people are going to do this on April 5th. It is not universally true that everyone's going to do it. Some people won't.
I want to recognize we're officially at time, and we still have another 40 questions. So I don't know, Dr.
I'll
Cait,
keep going if you want.
More minutes. Okay, so I want to recognize that. And for those who need to leave, we forgive you. But it sounds like Dr. Cait is still willing to answer a few more questions for us. And Deb, what do we have next?
Okay, let us see. Related to prior notes, any best practice when someone is being transferred to our ED from an outside facility who did not discuss concerns that they documented? This might even include concerns for child abuse, for example, and they didn't discuss.
So one of the things that's a very specific question, and it deals with interoperability between systems and health information exchange, and that's a little bit separate. But let's tackle the topic of things like suspected child abuse or other things. People will, at some rate, decide to suppress those notes under the privacy exception. One of the things that UCSD has created, and it predated the 21st Century Cures Act, is we created something called a confidential note type to house that kind of material. And that note type in our Epic instance is suppressed by virtue of the note type itself. And what we have educated our providers are, let's say there's a very sensitive conversation, and in the ONC vernacular would fall under the privacy exception or the harm exception, or both. is that you would put that specific content in the confidential note, and then you'd write your more general note in the progress note, which is billable and legal medical record and all of that. So confidential notes are not shared with patients. They're not part of the release of information process through medical records, and they don't go through health information exchange with other organizations. And that is an area where I think that there isn't a clear answer about whether it should stay that way. A lot of what I think will happen with the ONC rule in the 21st Century Cures Act is that the edge cases will get adjudicated over time. Right now, people are asking things that they aren't theoretical, they really happen, but nobody knows what the right answer is. And the federal government is not going to give us FAQs to the granularity of all these edge cases. We're all going to figure it out as a community ourselves. And I'm okay with that. And so if we end up, on April 5th, not showing something to a patient where it's eventually decided we should have been showing it all that time, I'm all right with that because, some of these are debatable. And, like I said, the easy answer is just to share everything and then point at Congress. But that's probably not the right way to approach it. We want the consideration of our clinical users and our patients in mind. And so, I tend to take these on a case-by-case basis and try and come up with something reasonable, recognizing that, our decisions may need to change in the future.
And I put in the chat box that next Monday we have Fabienne Bourgeois from Boston Children's who's joining our drop-in clinic, and she's thought about this a lot as well. So it might be a good question if you're going to join us on Monday, you can bring again there. Deb, what's next?
And your answer might be somewhat similar for this, but how about for inpatients with traumatic brain injury? Many are combative with emotional outbursts, lacking insight into their emotional regulation problems during their recovery. Do we have any shared guidelines on clinician note writing in TBI/trauma/rehab units?
So I'm going to try and generalize these questions. So let's say you're writing about a patient who is having behavioral issues in the hospital setting, and maybe needs to be medicated or even restrained. We'll take that as a general use case. That happens. It's a real phenomenon in the hospital. And I think that you can write objectively and neutrally about that, and even have the patient later on when they recover, or their proxy, if they have access to medical records, see that, because you don't need to do it in what I call the value-laden way. See, the patient acted like a big jerk. You're not going to write that in the note. And you're hopefully going to document your differential diagnosis, why you think that is. This may be an adverse reaction to opiate medication. This may be a side effect of or a phenomenon related to the patient's meningitis, or whatever it is. These are things that occur and are real phenomena in hospitalized patients and merit medical documentation about them. And there's nothing, I think, inherent in any of that that means it shouldn't be shared with the patient at some point, because it's a documentation of their care, which they have a right to. But I think that we do need to be mindful to write about things in a neutral language sense, and not in a judgmental sense. And it can be very easy to slip into some language that sounds judgmental on a later read. The term non-compliant is a premier example of this. And there's been a big cultural move to use non-adherent. The patient is not adhering to the regimen for various and sundry reasons, many of which may be out of the patient's control. So I think my general answer there is, yeah, that's in scope, but we should be writing about it in a neutral sense.
And I did not pay someone to ask this question, but I really like it. Since your research shows that patients are more likely to follow care plans if they read their notes, does your organization have a plan in place to encourage and help them access their portal and notes?
So a couple of things. One, not my research. It's just somebody else published that. Two, I don't know if that translates to post-discharge prescription adherence, but what a great research question. Three, we've kind of been, if there's any upside, and I know it's dangerous to frame it this way, if there's any upside to a global pandemic, we have all sharpened our telehealth capabilities, and all of us have onboarded a vast number of patients to our patient portal because it's usually mediated through that. So UCSD has easily doubled its MyChart population in the last year. Now, there are still opportunities. I think we clock around 60% or so of our patients who are followed at UCSD who are on MyChart. And there's always going to be some segment that just, that's not for me. I don't want to have it. Fine. But I have a very fresh request from one of our specialty services who says, how can we help onboard patients to the portal during the hospitalization? I mean, we give everyone an access code and a way to sign up. It's on their discharge instructions if they're not already active, but how can we be proactive in helping them? It's an open topic of discussion right now about how we can do that. One other thing that we haven't touched on but is related is that some EMR vendors, not all, but Epic does, has an inpatient version of the patient portal. It's called MyChart Bedside. And on our La Jolla campus, all of the hospital rooms have tablets. And the patient can sign on to MyChart Bedside and they can get vitals and labs and see their care team in real time. And we have not turned on the notes section, sorry Liz, not yet, of MyChart Bedside. But if they're if they're a general MyChart patient, they can just look in their app and see the notes. Right now, it's not a big deal because we're holding them till after discharge anyway. But in a future time where we're showing yesterday's note this morning, we'll be turning that on in MyChart Bedside, and the patient can read it and ask the questions and things like that. So there's a greater move to transparency, just in general. But I think it is an opportunity to find ways to help people onboard to a patient portal while they're in the hospital. And I suspect that this will help prompt some of those discussions about how to do that.
I also want to respond to that question because the person said, does your organization? And I was thinking of it from an OpenNotes perspective as opposed to a UC San Diego health perspective. But I did want to let folks know, and Amanda, if you could share this slide briefly, this would be great, is if you go to opennotes.org, there is a section specific for patients. And in there, we have these FAQs about the concept of OpenNotes that are written for a patient reader. And so if anyone wants to link to that, steal the information from the OpenNotes website, and everything we put on our website is under Creative Commons, so you can use it to cite us as some of the folks that put it together. There you go, thank you, at opennotes.org. And then a lot of the work we've been doing up until the Cures rule has been working with clinicians, but also patient organizations around the concept of asking for your notes, reading your notes, understanding your notes. And I know as we move in this post, everyone has their notes phase, we're doing more research in that area and really taking things beyond OpenNotes 1.0, but really like the OpenNotes expanded universe of research, looking into things like inpatient notes, proxies, reading notes, and beyond. So when you say your organization, I just wanted to share that perspective as well. We're not leaving you hanging. And Cait, I don't know if there's anything you want to add on to that. She's muted, but I think she says that sounds good.
Nope, that was great, Liz. We have resources and we're doing more to figure out more.
And Dr. Clay, we're about 10 minutes past. If you're still game, we have 100 people still hanging out and there's more questions.
I'm game.
Okay.
If a long note contains one sentence that meets the harm exclusion, but the rest of the note doesn't, can the entire note be excluded from sharing?
All right, what a great question. And again, apologies, but I'm going to generalize this to what if there's mixed content in a note? The 5 University of California health campuses have all been discussing with the University of California Office of the President use cases like this, because we're trying to see if we can harmonize between the 5 campuses with regard to our approach. And so things come up with, what if there's a little bit that has to do with a research project? What if there's a little bit that has to do with psychotherapy, or an allowed exception, the harm exception? And this goes back to my earlier statement that we do not have the technical tools right now to electronically read and parse notes to identify this. The tech just isn't there yet. And so it is likely that such a note that is really long and very valid, has one sentence that may invoke the harm exception, is going to be set up in the system to be shared by default. However, it should also be the case that your note author has the ability to unshare it at the time of writing that note and invoke the harm exception. So the answer to that from my perspective is there's no like below threshold content where you can't invoke an exception. I think if I was going to make a really gross analogy about, chili or something like that, and, you know, food contaminants, but let's not go there. I would say that if there's anything in a note where you can reasonably invoke an exception, then the whole note can be excluded and you can feel justified in that.
So this next question, I know you have Epic, so it might be a little different for those who don't have there are a number of vendors that have made this functionality available for a while. So it would be a different situation if they haven't had this for a while. But the question is, what are the sorts of interactions with EHR vendors necessary to make rollout go smoothly? And I think they're asking broadly, not just inpatient.
Fair enough. And if you're a relatively large healthcare organization or multi-specialty practice, then you probably have a lead technical support contact with your commercial EHR vendor. And whether that vendor is Epic or Cerner or Meditech or eClinicalWorks or NextGen or Athena or what have you, they have been thinking about this because there are requirements in the 21st Century Cures Act imposed on what are called actors, which the EHR vendors are a big group of actors in this space. And so they've been looking at that 1,200-page rule and they've been making plans of their own. If your EHR vendor is not to the point where they can give you the tools that you need, that is why the ONC provides a technical infeasibility exception as one of the 8 allowed exceptions. And one of the interesting things, and the ONC came out late with this in one of their FAQ documents, somebody asked them, hey, you know, we've all looked at this rule and we have taken this to mean that we need to proactively put information in the patient portal, like lab tests and clinical notes. Is that so? You know, once he came back and said, no, you actually don't have to do that. And all the CMIOs in the universe's head exploded because we've been doing all the work to do just that. And I think we all came to the same collective decision. We're going to do that anyway, because the ONC rule says, you know, the patient needs prompt access in a digestible electronic format, not a PDF, to the data elements in the US CDI. And we don't have another way to do that than put it in the patient portal using the EHR vendor code. I frame it like this, and this is not me. I'll take this, I'll cite Stephen Lane up at Sutter Health, who says that signing up for MyChart or the patient portal in general is essentially a tacit request for information, and you should treat it as such. So, are there going to be EHR vendors that are in different places in their development to give you the tools you need to be as granular as you want? Yes, absolutely. And I think that you should feel comfortable as an organization if you think that you can't achieve the level of parsing that you need to and that your vendor has a roadmap for it, but they're not there yet, then you can decide not to go yet in a given space. And you can cite the technical infeasibility exception. One thing I'll close this answer with, and this is notable in the ONC rule, is that anytime you make a decision like that, you need to write an organizational policy outlining that decision and its justification. It can't just be something that, you know, the ONC or a patient happens across. And you want to have documentation of the way you came to that decision, and you want to have policy justifying it. And so one thing I mentioned earlier is that California has state law about patients on a locked psychiatric unit on a hold, and you actually are not allowed to share the records with them. Well, there's a conflict there, right? So whatever decision we make on that point, we're going to put it in our institutional policy. On this patient population, we are doing this, here is why. And so I imagine everyone's going to have some situations like that because the EHR vendors aren't all in the same place.
Does UC San Diego allow messaging to inpatient attendings?
So that is related but different. And I did mention MyChart Bedside as our inpatient patient portal. And we have about a 25% prevalence of patients using it at any one time. That is functionality we have not yet turned on. It's something where it's the same conversation. The nurses say it's going to be burdensome. The docs say it's going to be burdensome. We haven't really figured out how to monitor or operationalize it yet. And it just hasn't been the highest priority. I think we eventually get there. And, you know, the great thing would be a patient messages their hospitalist and a consultant doc, and they have a three-way conversation about something that needs to be decided. You know, and that would be all upside, right? But how you get there is we're still figuring that out. So I think that's on our roadmap, but we don't have it turned on yet.
Maybe let's do like 1 or 2 more questions and end it in 20 minutes after the hour, because as Dr. Clay said, we are not paying him for his time. He's volunteering.
That was not meant as a dig, Lig. I was just making a joke.
So Deb, what else are we seeing?
So this might be also a question for Cait. Have you looked at whether providing notes has reduced costs in medical records? Typically, large sums are spent by healthcare systems on release of info in which HIM has to provide digital or paper copies to patients when they are not on OpenNotes and don't have access. So either or both of you can answer.
Why can't I learn? It's been a year. Why can't I learn to get off mute? So we actually don't have much information on that. And I think that that's something that we can start to look at as the new rule goes into effect. I mean, in the past, some organizations have made notes available, but not other parts of the record. So patients who really needed their record would still have to ask. I'm not sure, and maybe Brian, you know, whether the implementation of the view, transmit, download function helped with costs related to health information management.
I can cite some local experience at UCSD, and I think the answer, Cait, to that latter question is probably yes.
Yeah.
The ability of a patient in my chart to say, I would like a copy of my record, click, and then HIM gets that through Epic. There's already a pre-configured report for patient release that aggregates the content, and it gets a little bit scrubbed and then turned around in 48 hours, is a lot less work from a personnel standpoint of talking on the phone, patient asking for something, digging through the record to find the note, sending that to them by mail, you know. It's a lot easier with a view transmit and download function that is in some patient portals today. I think it's an open question whether OpenNotes has gone above and beyond that. But we've certainly seen when that functionality first became available, I think we peaked at 1,400 requests through my chart in a given month for patients who want a copy of their record. And then that settled down, and now it's routinely around 500. But it's very common. The other thing is that your HIM department is not just dealing with patients. They are probably the group that is scanning any paper that's generated in your organization. They are also dealing with release of record requests from other organizations and other entities. And so to try and get an outcome of decreased personnel time is hard because there's a lot of things that your medical records department does, and this is just a piece of it. That being said, with the ability to request just a PDF copy through the patient portal, that has reduced work in HIM at UCSD, and they've been able to put those resources elsewhere towards other efforts.
So no pressure, Deb, but what is the last big question we're going to cover today?
And again, I think this can be a Cait and Dr. Clay response, asking about the definition of harm. Is it just physical? Does it include emotional? And she said she or he said this is a hot topic in the mental health community.
It does not include, I mean, my understanding is it's a fairly strict interpretation, and it includes physical harm. So psychological distress does not count unless there's a strong reason to believe that that psychological distress is going to result in physical harm to the patient or another person. Brian, is that your interpretation?
I would agree with Cait's interpretation there. I'll go one farther and say that some of the providers I've explained this to immediately jump to the patient stress and anxiety may lead them to a place of self-harm, and my answer is always the same. You are the patient's physician and I am not. You are best served to adjudicate whether that is the case. If you think it is, then invoke the harm exception. And I kind of leave it at that. Yeah. Going back to I'm not trying to play fast and loose with the rules, but right now the decision to suppress a given note in a given situation is not reviewed. It is a decision by the note author at the time. And I think one of the open questions is how we audit and what the responsibility of the organization is even to audit. That is entirely unclear right now. I think we'll be doing some analytics and looking for patterns. Certainly one thing I want to identify is there a note author, physician or otherwise, who is taking the opportunity to unshare every note they write and effectively engaging in information blocking? I have responsibilities as the CMIO to let that person know what you're doing is probably illegal.
Mm-hmm.
One of the things that is in the Epic code, and this pertains to outpatient only, is you can have a user personalization setting that sets all your notes to unshare by default. And I'm aware of another organization who, before they went OpenNotes live, ran some analytics and found 700 doctors in their very large organization that had this setting set. And so they communicated, yeah, this setting's going away because it's essentially an information blocking setting, and you shouldn't have it. But it would be very interesting to know if people feel so strongly about not sharing notes, who is actually taking the time. I think that's one thing we'll be looking at later in 2021. Most people are on board with this. Most people see the upside, and most go-lives in most cases are complete non-events. And I think our data internally show that we're sharing tons of notes and patients are looking at about a quarter of them, which is great. And I think when we turn on all the other user types in just a couple of weeks, those numbers will go really high, and probably some stuff will come out of the woodwork that we didn't anticipate, but that's okay. This doesn't end in a couple of weeks. It's a journey that's ongoing. And I think that we just want to keep the North Star in mind that for the overwhelming majority of cases, it is good for patients to have ready access to their data. That includes their clinical notes. It includes when they're in the hospital. So I'll stop there. And I want to thank everybody for the great questions. This is clearly something that people are thinking a lot about and want to make sure they get right. And I think there is more discussion to come, and we will all learn how to get it right together.
Absolutely. And I like how you said it's a journey. We're going to learn more together, and perhaps we can have you back in a couple of months as you have more of that data and we all learn together. Thanks to the ton of people who stuck around for this bonus hours time. As we close, I want to say thank you again to Dr. Clay for joining us and sharing what they're learning at UC San Diego Health. This webinar has been recorded, and since you're here, you will receive a link to it as well as a link to where you can download the slides. So just give us a few days to get that up on YouTube. I predict it will be one of the most watched webinars of all time for us lately. And again, everyone is here is welcome to join us next week. We have these OpenNotes drop-in clinics, 2 hours every day. We're live. We have special expert guests. And for those of you who are asking the questions you're asking Dr. Clay today, I want to say someone else he mentioned, Dr. Stephen Lane from Sutter Health, will be live with us on Wednesday, March 31, and he understands this interoperability information blocking rule inside and out. So join us and ask those questions live. Remember to visit opennotes.org for free resources and information, and thank you so much for joining us.